Hi, welcome to Global Health 524, Health Disparities and Cultural Competency. If you haven't found the syllabus yet on Canvas, you can go there and find out all the logistics about the course, also how to get in contact with me. And we also had in the syllabus and in the welcome video info on the required reading. So here it is again. It is ordered through the bookstore if you want to pick it up on campus. It will be here, I believe, January 16th. So I apologize for that delay, but all your readings will be online until the book arrives. So don't worry about being behind on that. We're all at the same place. So the books will come in January 16th. If you want to get it from the bookstore, you can come then. If you want to order online now, that's fine. You may get it even faster. So this is the required one, Cultural Competence in Health Education and Health Promotion. And then the recommended reading again was The Spirit Catches You and You Fall Down. So great readings. If you have already read this, that's fine. You might want to pull it out and look at it. You might see some different things after going through this course. If you haven't read it, I do really recommend it. It's a great story with a good message, I think, that we all need to keep in mind. The course objectives are also available on your syllabus, but to briefly go through them, the first one is talking about kind of understanding we want to be able to identify, describe, and analyze the difference between a lot of these terms that we use in health disparities. And so some of the example terms that we have here are health status disparities versus health care disparities. Inequality and inequity, those are two different terms that you might hear, but they have different meanings. Socioeconomic status versus social determinants, and also institutional and individual biases. So see, these are some of the concepts that we'll be using. So we need to be familiar with these terms and how to use them. And then beyond that, we want to look at the implications of data collection in understanding and eliminating health disparities. It's one of those things we can't address what we don't know. So there's a lot of data that we need to collect that we're doing a better job on, but we need to see how that affects our understanding of health disparities. The third one is looking at those determinants of health, specifically individual, social, and environmental determinants of health, influence health outcomes and disparities among communities. So this is the main concept that you will usually hear within the topic of health disparities, is understanding these determinants and how they affect different groups of people and how that then translates into different health outcomes. The fourth one is looking at the systems. We want to analyze systems regarding access to services, utilization of services, literacy and language, and quality of care issues that impact health disparities. Kind of this idea of equal access and equal quality. Is it really equal for all groups? What kind of inherent or institutional biases are there that can limit groups from accessing the health care and services or quality that they need? And the fifth one is to apply strategies of cultural competency as a health professional. We also want it to translate into your daily interactions, but specifically in your professional role to eliminate health disparities. So understanding how we can bridge those differences. First, recognize them, recognize where we come from and our own background, and then how other groups might be different, and yes, look at similarities, but also allow for those differences and see how can we be culturally competent in addressing people from the different cultural backgrounds that they come from. So to give you just a little snippet, a little case study here of what we mean by health disparities and what we're going to be looking at throughout this course, what you see here is a slide of disparities among infant mortality. So infants are up to 12 months old, and we see the mortality rates for these groups broken down by race and ethnicity. And so on the green in the middle is the average for the United States. This was as of 2007, was 6.75. So yes, a low number compared to developing countries, but rather high compared to other high-end countries, a number of countries in Europe and Japan and the like. So not the best number, but still, it's, of course, a huge improvement from where we've come from. But if you take that number and you break it up by race and ethnic categories, what you see is a big difference between non-Hispanic Black groups on the far left at 13.3, and then on the far right we have to the right of the average, we have non-Hispanic white, Mexican, Cuban, Asian or Pacific Islander, and Central and South American. All these groups having much less than the average and much, much less than the non-Hispanic Black group. So the question is, why is that? Why is there a higher infant mortality rate among non-Hispanic Blacks? And another concept that comes with this is that, is this just? Is this just something that can't be helped, or is this something that is wrong with the system, is this something that can be fixed? And how do we go about doing that is the question we want to know. So when we're looking at infant mortality, that first one was saying, okay, let's look at it by race and ethnicity, but it can also vary by a number of other things. It can also vary by geography or your environment and where you live. So what this slide shows is infant mortality by location or wards within the District of Columbia, Washington, D.C. And so it shows the 8 wards here within Washington, D.C. And we see a big difference again in infant mortality in those groups. So we see Ward 3 with very, very low. Again, the green is 2005 data, the orange is 2009. And between the two of them, every area has made improvements, so that's a good thing. But in Ward 3, we're looking at 2.5 as an infant mortality, which is among one of the best numbers you could see in the world, all the way over to Ward 8, which has been hovering around 20 deaths as an infant mortality rate, deaths per 1,000. And so this is a big, big difference all within Washington, D.C. These neighborhoods are not very far from each other, but there's a big difference between them. So this one is looking at environmental determinants, obviously, just difference in geography. But in the previous one, looking at race, ethnicity, maybe we would also see race and ethnic differences between these different locations. And in fact, we do. We'll see that later, that the wards have different ethnic and racial makeups or compositions that happen to correlate with these patterns that we see in infant mortality. So we see local variations, and so if this kind of makes the case for why to collect data. If we only collected data on Washington, D.C., we'd say, oh, they're at 10, so they definitely still need improvement, but, maybe there's places like Detroit that have a much worse average overall, and so it wouldn't be a priority. But when you break it down, the smaller you get, you can see the differences between these groups. And so the better data you have, the more you're able to really target or be strategic on which groups, which neighborhoods, which communities need targeted help as far as addressing this disparity. So again, we can pan out a little bit more and look at the U.S. as a whole. And again, in 2007, the average was 6.75. Here in 2010, it's gone down to 6.15. So again, we've made improvements across the United States. But as we look at different states, we see more differences in the infant mortality rate depending on location again. So the dark green has an average infant mortality of less than 5. And then as it lightens up, it increases until you get to the deep blue, which has an average of 8 or higher. So this is Mississippi and Alabama, where the infant mortality is much greater than it is in other states. And we can also look at this globally. So where U.S. falls is in the very light pink, which is between 2 and 10 deaths per 1,000 births. So we fall in that range, which puts us again in the range of Europe, Japan, Australia, Saudi Arabia also in that group, and I believe Chile as well. But then as it gets darker, you see the areas that are still having just major issues, and these are, whether it's addressing the infrastructure, the healthcare system, the sanitization, there's all these issues, just the economic system as a whole that's blocking that kind of progress, mostly in sub-Saharan Africa, but the other hotspots are Afghanistan and Pakistan. And so we see from this that where those targeted areas are, if we want to address infant mortality, if usually people that get involved in health disparities, it's because, like I said, they feel there's this injustice. It's not right that there's this difference between the death rates between the United States and, say, Congo. And so having this data helps us know where are we making progress, but also where do we need to put our most efforts, and where do we need to find unique applications or strategies based on that location. So we've looked at infant mortality based on race and ethnicity, and we've also done it based on location, whether it's very local, neighborhood level, to state level, to then national level. But those are two factors, two ways of looking at health disparities. Another variable you can look at is income. This is something we don't tend to look at very much in the United States. We tend to focus on race and ethnicity data and only looking at the differences based on that. But if you go throughout the world, if you go throughout Europe, they will look at income differences and essentially class differences that we're seeing here. So what this shows is 4 strata of countries, of nations, between the very high income groups on the far right, middle income next in the green, orange for lower middle, and then the red for the very low income countries, and their number of deaths of infants, so their infant mortality rate. And we see the big difference that income makes in addressing things like infant mortality. And so how can we help these countries address what they need to increase their infant mortality rate? Do they have to get to our income level to be able to address that? Or are there different ways of addressing this disparity without having to follow the same exact steps that other high-income countries have gone through? If you want more information on this, the data source there at the bottom is from the World Bank. They have a number of these statistics, and you can kind of click different variables and see the maps for yourself, and you can create different maps or bar graphs and see how things compare. It's pretty interesting, kind of fun. So here's another map that I made on the World Bank site, and this one is looking at improved sanitation facilities. So these are percent of the population with access to improved sanitation facilities. So the gray is no data, and then the green areas we see after that are areas that are at 100% or fairly close to 100% of the population having access to improved sanitation facilities. The yellow is in the range of the upper 80s, the orange is in the mid-60s to the mid-80s, and then the deep red is the areas that have less than 6%, so a third of the population not having access to improved sanitation facilities. And as you can see, it fairly closely mirrors both our income levels and our infant mortality rates that we see in the same regions being affected by these problems. So one of the questions that this highlights is, do we really need increased income for these countries, or do we need improved sanitation? Is this the factor that would really ties to infant mortality closer than anything else? And if we address this, then we're going to see improved infant mortality rates. Or is it income? Is it healthcare? What is the primary factor? What is the strongest factor? In reality, of course, all of these factors are related, but looking at the different data and looking for correlates helps us understand how to address these problems in the most strategic way. So we've mentioned some determinants of health. We looked at environmental determinants in the natural and built environment. When I showed you the different maps of the neighborhood, the states, and then also the world map, what's kind of assumed is that when you're in a different geography, you have kind of a different environment, whether it's the natural environment, the quality of the water that you're exposed to, or the built environment, and that determining the air pollution that you face, or what materials are your homes built out of. Do you have, again, the sanitation facilities? What kind of environment are people living in? The environment encompasses this outer layer of factors. Not saying it's the most distal or the least important, but it's simply the most broad and can affect the largest number of people all in one swath. When we have poor air pollution, poor air quality, high air pollution in Southern California, it affects millions and millions of people versus a social system that maybe just is affecting one neighborhood or one city, or a healthcare system that's kind of centralized around one hospital. So the environment is this broad topic of determinants that can affect disparities among larger groups. It can also affect, of course, the disparities in smaller, more localized ways. Next, we have the socioeconomic determinants, and these are things like income, education, profession. Those are some of the most often and easiest measured, but there's also issues of culture and religion and groupings of people and how they're grouped. And so those things are harder to measure, but we can look at these different groups and see, like we saw with the income levels in the countries, how health status, how health outcomes varied based on their income level. And then central we have individual, and this is where there are determinants, both genetics as well as behavior, that determine health outcomes. You know, there's been a lot of research in the last 10 to 20 years, especially the last 10, on looking at different health outcomes based on different genes and just wanting to, you know, see if they can link certain health outcomes to these genes, and then is that where they can address it. But there's also, of course, a big factor played by behavior. And behavior, of course, is largely shaped by our culture, our social sphere, our profession, our education, our income, which is, of course, shaped by the environment that we find ourselves in and the opportunities that we have. So, again, they are all linked, but different people, different groups focus on maybe different determinants, and which one, it's always a debate, which one has the greatest impact. You're allowed to form your own opinion. Of course, it's an intricate web, but maybe one of those factors interests you the most, and it's not that you think it's the most important, but it's the one you most enjoy working with. The best programs will address multiple determinants all at once. So we've been talking about variables as far as measuring health disparities, and for those different determinant levels, these are some of the variables that are often used, just to have them listed out for you. For individual determinants, we're looking at demographics. We're looking at race, ethnicity, gender, age. In the socioeconomic category, we have things, like I mentioned, of education, income, profession, nationality, and religion. These we don't tend to measure as much. And then we have variables in that environmental determinant category. So these we usually measure by address or zip code, and then the comparison of urban or rural. Those are the two main variables that we'll use to look at then what is the environment like around maybe each of those zip code areas or between the urban and rural setting. The last one, and this is one we really don't tend to measure or look at, but it's around the area of culture. And culture I just left out on its own because we are going to be looking at it separately. It is a big portion of this class, and it doesn't fit quite as well cleanly into either the socioeconomic or the individual category. It is also this broader thing that sometimes transcends or, you know, kind of spreads across all three categories, because our culture shapes the environment that we build even, and what is the focus or priority or where we choose to live. Culture can shape a lot of those things as far as what we value, what we find beautiful, how we view the world, purpose in life, all of those things. And those things I just described are all part of worldview. And so we're going to get to look at that. That's not something that's usually often measured as far as how it relates to health disparities, but it is a big part of that that can provide some insight on why certain groups may be interacting with the healthcare system the way they are, or within their environment, or between different social groups, and ultimately then how that leads to health outcomes. So one of your readings that I've given you for this module is the CDC Health Disparities Report. This came out in 2013, so fairly recent. Some of the sections will look specifically at the social determinants of health and then the resulting health disparities that we're currently seeing. The next few will look at environmental hazards. After that, we'll look at healthcare access and preventive services. And finally, then there's some chapters on behavioral risk factors. So these are the four areas that they break it up into. So we see, as I had mentioned before, social, environmental, and individual, but then they also have the separate category just looking at healthcare access. And that's often a way that disparities are measured before looking at specifically the healthcare system. If you notice there's a hyphen here, if you are at all picky about your word choice and word use and how things are spelled, I choose to use healthcare as one word. I'm kind of progressive in that. I'm not often, but Europe, the rest of the world has kind of gone ahead and made that one word its own term. In the American English language, traditionally it has been two words, but that's been changing. And so the U.S. government is currently taking this middle ground and they're hyphenating the word. Either way is fine with me. You can do whatever you're comfortable with, but if you see me make it one word, I'm aware of that. I'm kind of doing it intentionally because it has kind of become its own noun. So there's the English background for those of you English lovers out there. So using those variables in those different determinant categories, what are we going to be looking at? We're looking at two main things, mortality and morbidity. So mortality, we have these common measured categories of coronary heart disease, drug-induced mortality, homicide, infant mortality, motor vehicle mortality, and suicide. So these are some of the top killers in the U.S. Under morbidity, some of the top issues that we're looking at the U.S. and that specifically are within the CDC report are asthma, cancer, diabetes, HIV, hypertension, obesity, periodontitis, preterm births, smoking, tuberculosis, vaccinations. And then I added on the list mental illness. That's not currently in that CDC report, but that is an area of morbidity that can be like a disability that we definitely see disparities in between different groups. So here is a screenshot of the table of contents for that CDC report, so just to help you understand what I'm asking you to do, because it is 184 pages. I'm not asking you to read all of that along with your other readings. I want everyone to read the foreword, so the first 5 pages, the introduction, understand where they're coming from. And here you see the 4 different determinants: social, environmental, healthcare, and behavioral or individual. So I want you to pick one of these determinants and read through that section as far as what we're seeing in the U.S. currently. Where are the disparities within one of these determinants? So pick which one most interests you. It's still a good idea to skim the others, have an idea what they're talking about, but I understand that some of these sections will be a bit dry for you and some you'll get excited about, and that's fine. In the next section, there's this chapter on morbidity, and all of these, and then this chapter on mortality. So within morbidity, pick one of the morbidity issues that most interests you and read that one. And then within mortality, pick one that most interests you. So overall, you'll be picking 3 things. You'll be picking a determinant, you'll be picking a morbidity, and you'll be picking a mortality. And these specifically is probably what you're most going to be commenting on in your discussions in the online forum for this week. You can also, of course, comment on the video that's included. That's a really interesting little trailer for a documentary that's out. There's also some other readings that hopefully you'll find interesting, but I know that there's going to be some numbers in here that are going to get your attention and you're going to want to talk about. And so pick some of those and use them in your online discussion.